So yeah, I'm talking about beyond infrastructure. So, and the idea here is to leverage the investments that are being made in access to water and sanitation in order to get the assumed, when we assume or we prioritize these investments for health reasons, and yet what we know is that it's not enough just to invest in the hardware. And so I'm going to be talking a little bit about what else we need. Okay. So when we do this complementary activities for these infrastructure investments, we do an at-scale approach. And basically, very aware of the transaction costs of coordination, it's trying to, with the least onerous time and energy to coordinate, but recognizing that you need a systems approach. There's a lot of sectors involved, there's a lot of stakeholders involved, there's different options and approaches. And so we take a systems approach, okay? We use a hygiene improvement framework, which recognizes the importance of hardware, but goes beyond really to look at behavior as sort of the limiting factor to get that additional health impact from your investments. Prioritizing sustainability by embedding our interventions in existing institutions and activities. And finally, we want at scale means that we're talking about something where you can really see a public health impact from your interventions. So I mentioned the hygiene improvement framework. So again, certainly you need taps and toilets and pumps and pipes and sinks and soap to do improved hygiene, but that's not all you need. And so then we're focusing on this talk on behavior, which is really about okay, so a lot of things that go into behavior change, a lot of social marketing activities, community mobilization, mass media campaigns, school campaigns, all of the things that go into really changing social norms, individual by individual. And then sort of the institutional capacity issues that we lump under enabling environment, which is the policy framework, the access to financing, getting communities mobilization, the strong monitoring and environment, monitoring and evaluation framework. All of those kind of enable these, the overall improvement in hygiene, reduce diarrheal disease. Okay, so we have three behaviors specifically that we're really focused on that we know have an evidence base that do reduce diarrheal disease. First one is safe feces disposal, and it can reduce diarrheal disease, especially in our target population of children under 5, by about 30%. Hand washing with soap at critical times to break that transmission is also a very effective intervention. Probably the most bang for your buck, 43%. And all of these percentages have brackets around them, but still are solid investments in reducing diarrheal disease. Safe storage and treatment of drinking water in the household, since much contamination happens during transport and storage, from 20 to 50% reductions in diarrhea. Okay, so I'm going to quickly talk about a case study that we did in Ethiopia. They called it community-led total behavior change in hygiene and sanitation in Ankara. And so the point is that it followed these sort of best practices. It was embedded in national and the Ankara state processes. It was actually the World Bank's Water and Sanitation Program asked USAID if we could help with the implementation of the Ethiopia's national hygiene and sanitation strategy. So working with the state of Ankara, and really built again around an existing program, the Ethiopia's very impressive National Health Extension Program. These health extensions workers went out, and I put some examples on all the tables of some simple, very pictorial tools that you can use to negotiate improved hygiene practices in the household. And again, they focus on these three key behaviors of hand washing, sanitation, and household water management. So the idea is that you would negotiate with the household to see what current practice are they doing, and then talk about what are the barriers to moving closer towards what we know as the ideal behavior. Not the idea that you have to go from open defecation to a $300 ventilated improved pit latrine in one step, but there's smaller steps that you can take with the idea of moving up the sanitation ladder as your finances and as your behaviors change alongside. So we did some interesting research out of this. It's a multiple regression to look at what parts of our intervention contributed most to increase latrine ownership in Amhara State. So one of the sort of trademark activities in a community-led total sanitation approach is this walk of shame, where the community walks through and identifies where they see human excreta on the ground in the village. So households that the community had done this walk of shame were 2.23 times more likely to have invested in a latrine than communities where people didn't do that. And then these household visits by the health extension workers, where they negotiated improved behaviors, had people were 5 times more likely to have a latrine than if they had not been visited. And the thing about these characteristics from the multiple regression is that they're additive. Now we have a couple of characteristics that are perceptions when we ask about, and interestingly, the perceptions were both related to the community, not just to the household. Having a latrine, believing that having a latrine contributes to the community's health, 2.6 times more likely, and that it contributes to the community's development 1.8 times. So if you had a household that the community had done the walk of shame, that they had been visited by a health worker, and that they had these beliefs, they are over 8 times more likely to have invested in a latrine. So this gives us information for, it's interesting that these last two beliefs are almost more governance things, having a community identity. So it gives you ideas on future programming in as we're trying to not just increase access to sanitation, but also the behavioral side of correct and consistent use. Okay. So the results in Egypt, it was not just USAID funded, it was also WSP and the government of Ankara, but the total population reached was 5.8 million people, and 2.8 million started using some kind of basic sanitation out of that. And another characteristic of the latrines was that they would always have a hand washing station. It wasn't just a latrine, it was a latrine and a hand washing station. Okay, so a couple challenges I just want to lay on the table here before I wrap up. One of them is that for us, especially USAID is a tax-funded institution. When we talk about the importance of partnership, we also get into some difficulties in attributing results. And when our taxpayers want to know what our money paid for, it's difficult to tease out that from the overall success of the program. So it's maybe more of a dilemma for USAID than others, but I'm going to put it out there. The other thing is the trade-off of quantity versus quality when you're trying to scale up rapidly. And especially when you're just counting numbers, the danger of losing the quality side and then the behavioral, the correct and consistent use suffering as a consequence. So another challenge that we're dealing with. And then finally, the evaluation of the sustainability. We have research ongoing to see how the long-term adoption and the long-term sustainability of these investments. So we don't actually know of that just yet. Okay, so I wanted to make this short so we could get some discussion. So that's it for me. Thank you.
Thanks very much, Rochelle. Thanks for sticking to the time. That always makes my life as a chair much easier. And as a reward, I think we should allow a few questions or comments from anyone in the audience who has perhaps worked on similar issues, or anyone here from Ethiopia who wants to add anything.